joined the NYU Silver School of Social Work recently in September of 2011 as professor and director of the McSilver Institute for Poverty Policy and Research. Prior to joining Silver, she served as the head of the Division of Mental Health Services Research at Mount Sinai. She has received substantial federal funding for research focused on meeting the mental health and health prevention needs of inner-city youth and families. Working with colleagues in the field, she developed a substantial body of research findings around engagement practices to improve involvement in family-based HIV prevention programs and mental health services by children, youth, and families in poverty-impacted urban areas. She has significant expertise in services and implementation research methods, as well as 15 years of experience conducting HIV prevention and care-oriented studies. Recently, she's been with the McSilver Institute and oversees numerous applied research studies aimed at addressing the root causes of poverty, as well as examining approaches to reduce its effects. Mary is also my boss at NYU. So I'd like to please join me in welcoming Mary.
Thank you, Tom. You did a great job. It's always good to have an introduction by somebody that I think so highly of as a colleague. It really is my privilege to talk to you today for 15 minutes to try to boil down what do we know from the evidence base, what do we know from science and research that should influence what we do in those very early encounters that we have with young people and their families. And I have to tell you that this TED Talk format is a little tricky, because I too have some slides, but really trying to put in words big ideas about how what the research says should guide what we do when we leave this conference on Wednesday is what I'm going to try to accomplish. Dr. Insel, who supported this work, he let me know that he's only been at NIMH for 9.5 years, but before even your predecessor, really has supported my work, Kimberly Hope, who's in the first row of the audience, to really think hard about how do we close the gap between science and service. How do we think about infusing the breakthroughs that NIMH is trying to bring to the forefront? How do we make sure that those in need get influenced and that you as providers know what that science is? So that's what I'm going to try to do today. And I'm going to set this talk within the crisis that we have within kids' mental health services. Yesterday, if you had the pleasure to see our New York State Commissioner of Mental Health, Mike Hogan, he was here, and Mike travels with a set of slides that suggests that, at least in our state, but in some of your states as well, the modal number of child mental health visits is 1, followed by 2. He does it much better than I do. But Mike's point, when he travels with those slides, is that the early encounters, the first encounters that we have with young people and their families are critically important. Dr. Insel's Institute, many of our federal agencies have identified that anywhere from 2/3 to 3/4 of kids and their families that need contact with appropriate evidence-informed mental health care, they never see that here. And in fact, many of us in our system see the consequences of not meeting those needs early, not meeting those needs in an evidence-informed way. We see those consequences in our emergency rooms, our juvenile justice facilities, in the urban schools, elementary, junior high, and high schools that we collaborate with in New York City. Significant consequences. Numbers of federal reports suggest that in inner city communities like the ones that Kimberly and I many times collaborate with, urban kids who are affected by serious stressors related to poverty actually are least likely to get appropriate care, evidence-informed care. So the challenge to us is how do we address those needs, given this slide, and usually what's an easy laugh in an audience like this is when I ask providers, have you ever had a no-show? That in fact, the no-shows represent incredible missed opportunities to serve kids and families in need, but also really plague providers who are ready to help children, to help families, but also providers who are now being increasingly judged by this thing called productivity. No-shows represent real system challenges as well. As we think about the resources available for children's mental health, no-shows make our systems highly inefficient and potentially not nearly as effective. And so this becomes a very important outcome, is are there things that we can do in an evidence-informed way to decrease no-shows, to increase efficiencies and effectiveness of care, so that kids don't come in and out of service systems. They actually get some of their needs met, as well as their families. The average length of stay, particularly in urban settings, can be approximately 2 or 3 sessions. Those of you that went to any healthy professional school, whether it be in medicine, social work in my case, psychology, know that we were not issued a magic wand upon graduation. And so how we think about contacts that are coherent, that are sufficiently long enough or intense enough to actually deliver a dose of evidence-informed care that makes sense, that can be tied to positive outcomes, is really our challenge here. And I don't want to put any pressure on you in this particular audience, but I'm going to. Because in fact, what we know from emerging data from our own lab and others across the country is that what happens in that single encounter can influence a path of a child and a family, but also how communities, families think about mental health and getting those needs met from the systems that we've set up. Why do I think our reputation depends on that single encounter? Well, this is emerging research from a couple of different research labs across the country that suggests that if families have what they perceive to be a negative encounter, they often don't return for services. But worse yet, they tell a whole bunch of people. They talk to their families. They tell their friends, oh, don't go near that clinic. They tell their neighbors. Potentially, they influence the reputation of mental health in general, our treatments. And many times what I think drives a finding that we've published several times now is it delays actually families seeking help. So Dr. Insel made a very important point around early intervention. When your social network, when your community is dissuading you from going to get that help, it often makes the challenge of serving that child and that family even more difficult. So how do I kind of convey to you what hundreds and hundreds of families have told us in our longitudinal studies around how they enter that single encounter, what are some of their concerns, and then what needs to happen in that first encounter. So parents come to this meeting, she doesn't look very excited to see us, does she? Come to the first encounters with our systems with some dread, potentially real confusion, fear about being blamed, but also even fear about misinformation. I love the fact that we busted those myths, because many of our families have been told what's going to happen at that first encounter. Particularly, I for years was the director of clinical services provided in our outpatient clinics and adults and children to the large hospital. Fear that upon entry in a child psychiatry clinic, you begin to give a medication you didn't want, or even worse, that you would have no choice in the matter, be forced to do something. So fears, incredibly important. Also significant questions. And then a fair amount of stress. Parents, in some ways, are people too, and this t-shirt, if parents were to wear them into our first encounter, some of those stresses and strains are related to children and the difficulties that they experience. Others are their own circumstances and situations. And much of what parents do hope as they cross our threshold is that there might be some relief from the dread, from the confusion, from the questions, and from the stressors and strains that they experience. So what are some of the goals of the first encounter? In some ways, in addition to covering, anyone have any paperwork in their system? To making sure that administratively you get done what you need to do in that first encounter, we also need to work on some of these attributes and perceptions. Dread needs to become relief, confusion, some additional clarity, fear, some hope, and questions. I should ask you information or answers. It's so important for us to really understand that the data suggests that as parents come to our service systems, they have not made up their mind whether they will be back. As a matter of fact, I have the real privilege of supervising a number of research-oriented community workers, parent advocates, parents as our partners in a number of clinical trials and community-based research projects. And that very talented community staff, parent staff, once made a training video. And they titled that training video, "I went for an intake and never came back." And the crux of that video was really their explaining that they're at this first encounter to see if this is a right decision for themselves, for their child, whether they have confidence that they can get the help that they need. And they're making the decision. And unfortunately, for years in my own clinical life, I was signing children and families up for life. And so that knowledge that what will help families make the decision to return one more time is very, very important. What do families need to leave the meeting, that first clinical encounter? The first thing they need to know is how common. Am I alone? And the numbers, Dr. Insel, that you put up for us are just stunning. In terms of many, many families are struggling with a number of issues related to their kids. But many families also report feeling incredibly alone and a lot of stigma around their child having difficulties. Are there things that I can do to help my child do better? What are the treatment options? Which ones work? Which ones don't work? How do they work? It's incredibly important. What would mental health care actually involve? In some ways, it's a very simple question. What would I have to do to get the help that my child would need so that they can do better in different domains of their life? And then choice is starting to emerge in the research literature. It's incredibly important. Coercion might have a family come back a session or two more. But in terms of what needs to happen in terms of behavioral activation, motivation, coercion often doesn't lead to families really becoming our partners on behalf of their children. So as you think about, as a family member, as a parent leaves that first clinical encounter, you're really trying to get, in some ways, some practical utterances that reflect that this session went well. What did I think about is some markers. If you have a family leave your clinic and they say, that wasn't so bad. Or he or she, they seemed okay. And better than that, they seemed confident, they seemed knowledgeable, they seemed reassuring. If a family came away saying, I don't feel blamed, criticized, talked down to, that's a good thing. This person tried very hard to understand my situation. That in some ways, this is a common difficulty that can be addressed. I have some new information. I learned something that I didn't know before. And the best of all is that upon leaving that first encounter, if there is a need, I think I'm going to give this one more try. So with that, I think that those are the best evidence I can give you for the single encounter, and I'm happy with Dr. Insel to stay around after in this beautiful room and take any questions. Thank you.